Good morning. My name is Nan Freund, and on behalf of the Association of Educational Therapists, it's my pleasure to welcome you to the second part of our webinar, Mood Disorders in School, Reshaping Best Practices for Clinicians and Classrooms. If you missed part one, it was aired in September and elaborated on the types of mood disorders and their symptoms. The video of part one is available on the AET website in the webinar archives. In today's webinar, we'll learn about school accommodations that can help children with mood disorders. But before we begin, I just want to share a little information about AET. AET is the National Professional Association for Educational Therapists. AET sets standards and ethics for the professional practice of educational therapy and provides ongoing professional development for its members and the public. I'm delighted to once again introduce today's presenters. Paula Dufault is a board-certified educational therapist in Southern California, where she conducts a private educational therapy practice that includes children and adults with learning differences and mood disorders. In addition, she's an educational specialist in the Orange County, California public school system. Paula has a personal interest in students who come to school with recognized medical mood disorders and what schools can do to promote the educational well-being of these children. Christine Hartley is the parent of a child with a mood disorder and is the director of Children's Services Divorce Recovery Workshop in Newport Beach, California. She works tirelessly to educate others about mood disorders and to remove the stigma that prevents children from receiving proper accommodations in school. Together, Paula and Christine facilitate a monthly support group for caregivers of family members with mood disorders. Please welcome Paula and Christine.
Thanks everyone for joining us today. Before we begin, we'd like to apologize for our part one. We had a lot of audio interference and we do really truly apologize for that. Hopefully we worked out all the bugs as we get started today. We'd like to remind the audience that today's talking points represent a combination of experience and research, and we recognize that there are many sound accommodations that support symptoms that we're outlining today. For our outcomes today, we're hoping that participants will be able to recognize symptoms of anxiety and mood disorders that impair a student's social and academic performance. And of course, we're going to pony that with participants being able to identify those accommodations that are appropriate in an educational setting. And that could mean a private office, an ed therapist office, a professional office also. In part one of Reshaping Best Practices, we focus on how to recognize symptoms of mood disorders, anxiety, and depression in an educational setting. We believe that when our attention is primarily given to symptoms, then we can uncover opportunities to support students who may have been formally diagnosed or those who have not received a mental health diagnosis. We also emphasized in part one the joining of our individual professions, our disciplines, to comprise the team, and then that team's going to serve the whole child. It's our goal and vision, and I'm sure yours, that we ensure we're doing our best to prevent, combat, and reduce occurrences of the school failure that we talked about in part one amongst this population. Stigma remains the most important hurdle we face against mental illness as a nation. Combined that with further need to educate administrators and personnel and professionals that work in mental health with children. So we certainly applaud your attendance today with us. We'd like you to leave today with a clearer understanding of your role in reshaping best practices by putting the accommodations we're going to talk about into practice.
For those of you who attended part one of Reshaping Best Practices, we talked about a very powerful statistic. 50% of all children that are served in special education drop out. That is, of course, a very staggering statistic. So that leads us to wonder what is occurring with the children who are not served under special education. When we're looking at the learning environment, we have a few key considerations to make. We need to think outside the typical scope of services and accommodations and interventions that we would typically see as educators. We're not looking at the accommodations and settings that we're used to with the DD population or students with learning disabilities. We really have to challenge the way that we think and the way that we approach shaping the environment to promote a better space that these children can receive their education. I'm going to talk quickly about 5 key components. Number one, research tells us that environmental factors play a very key role in mood cycling for things like depression and bipolar disorder, as well as the manifestation of anxiety. Number two, we need to take a very meaningful look at the sensory profile of these children. We know that children with mood disorders and anxiety often have very high sensory profiles. They're highly sensitive to auditory stimuli, to social interactions, and really exhibit a lot of anxiety with self-comparison to their peers. This is true across the board with children who are depressed, children who have bipolar disorder, as well as children who have anxiety. Number three, can the given environment that your student is placed in actually support the accommodations that we're suggesting to you today? So again, that's where we look at reshaping that environment. If you have a list of accommodations that you already have in your mind or that you gather through today's talk, is the current placement for that child actually able to support these accommodations? Number four, what does the data from other professionals, when compared together, tell you about the child's response to any given environment? This is really what Paula talked about when we bring the other professionals and paraprofessionals together. We really need to be taking data within our own environments and forming a team to analyze that data together to see how that child is indeed performing in each setting. Number five, and this is the most important factor, is flexibility. We need to be willing and able to change that environment according to symptoms. We know that children with mood disorders and anxiety have difficulty shifting set. So 2 things are at work here. 1, that we're flexible to change their environment, and 2, that we try to preemptively predict what the best environment is, because we know that moving from environment to environment and changing their mindset can be very difficult for these children. The first accommodation that we're going to get into today is seasonal variability of mood, energy, and sleep. Oftentimes children with either seasonal affect disorder, depression, or bipolar disorder tend to slide into depression during the winter months. We also have evidence that supports that they become more hypomanic, manic, or activated in the spring. Like we said, depression can come with seasonal changes and variability. When we're looking at a child with bipolar disorder, a lot of them have a sleep-wake reversal. It's an actual reversal of their circadian rhythms. So oftentimes these children will not be ready to start their day at 8 a.m. with the typical child. They tend to have more energy at night and less energy during the day. Not all children with mood disorders present in this fashion, but it is a meaningful consideration to make. Home to school communication is one of the most key important factors that you'll hear throughout our presentation today. If you have 1 or 2 children on your caseload, having a daily email system really doesn't take up that much of your time. It's maybe a half an hour before school starts, you have this email communication with the parent. That way, if there's something happening with the child, you're going to know before that child enters your environment. And this stands to be true at the end of that child's day or throughout the day. If there's something notable that the parent needs to understand, then you can give them a quick email. Two things happen. One, the parent is getting more information about what's happening at school, what to expect at home. And two, you're understanding what mood that you may be receiving your student in to school that day. When we allow time to adjust to the environment, we're actually saving time, not wasting time. This can look like a period of time where the child is perhaps performing non-academic tasks first thing in the morning when they're less available and enrolled for learning. It can also mean something as drastic as an AM nap, and this is a very real consideration to make, especially if your child is experiencing a deep depression or other things that come along with having mood disorders. Allowing flexibility to accommodate their fatigue. If you have a child that's napping, there's not a lot you could do. But if you have a child that's tired, there's various ways that you can keep them enrolled in the classroom, but perhaps not place any demands. If the child needs to start their day in the resource room, maybe they can have a book on tape that they listen to that's still an academic task, but it's giving them an opportunity to warm up to their day. This here flexible day or a modified day, we all want kids in school from 8 a.m. to 3 p.m. If you indeed have a student that has a diagnosis and you get information or documentation from the physician requesting that a modified school day be put into place, this is an accommodation to take very seriously, and it's a difficult one to make. If the physician has gone so far as to say that the student may benefit from a modified day, it's very important that we follow this. A couple different reasons. One, the child may have medication considerations, but most importantly, we want the children that we are educating to have success. If that child cannot be available for learning until 10 a.m., we don't want them to have an unsuccessful morning. If they've held it together all day long and by 1 o'clock, they can't work anymore, considering sending them home is actually saving the self-esteem and motivation of that child on a daily basis. Now we're going to talk about movability. This isn't simple grumpy mood or sadness or the typical emotions that you would see. This is an emotional dysregulation. It's rapid and has exaggerated changes in mood. It's excessive and it's disproportionate responses to the event. It is a marked reactivity. It's very challenging to deal with in a school setting. This can be on a daily basis. It could be multiple times in the day or seasonal. When we talk about a staff member, we really want to challenge you to uncover who your student feels bonded to and connected to. It's not the convenient staff member that makes sense for us as administrators or educators. It is who we think that that student is going to bond to and trust. Again, as I mentioned earlier, that home to school communication in the email, you could have a daily log or something that you work out with the student and the parent. Allowing time to adjust to that environment, again, that giving them some downtime or an acclimation period is very important. When we talk about a reduction of academic demands, that's going to be subjective to the student, the situation, and of course the teacher. Us as educators are very uncomfortable with modifying a student's work or not presenting expectations to that student. This may go outside your comfort zone, but we want to keep the student in school and successfully making progress. And if we need to lower their demand, that's a success. One of the main important factors in repeated failure is something like school refusal. It's a very difficult thing to treat once it takes shape. We can avoid that by remaining flexible in our academic demands according to the child's symptoms. Because remember, these are not behaviors, these are actual symptoms of a medical problem. Where does a child feel comfortable? How can we separate them to reduce that sensory input that overloads the child? If you look at something as drastic placement as an NPS, a therapeutic day school, they will actually take data over time to uncover where that student functions best when they're on sensory overload. A lot of these students have sensory integration difficulties that make it nearly impossible for them to function in the environment, let alone to absorb anything that you're trying to teach them. What level of counseling does your student need? I think one of the things I'd like to stress the most is we often do trial and error with many things, and that is appropriate in certain situations. But when it comes to counseling, we don't want to put a student through the lowest intervention and ride them on up the ladder from a peer group to the guidance counselor, then to the school psychologist. If we know that that child is very impaired and they may need tier 3 district level behavioral counseling, it's very important that we strike where that student's level of need is. So we don't put a child through unnecessary transitions, and most importantly, having to acclimate and trust multiple adults. Anxiety is, as we talked about in part 1, often unseen, and most importantly, it's uncontrollable. We really need to approach this with great respect and a deep understanding that this is oftentimes a physiological response that a child absolutely cannot control. And it's a very scary experience. I'm sure we all as adults have experienced any type of mild anxiety, from nerves at a new job. These students experience this at a level that we almost cannot comprehend. We can see perfectionism, real fear, worry, and even refusal to attempt work because of their fears of failure. Remember, they're scared. They won't ask when they need a break. Maybe a child with a mood disorder will be more likely to have insight to themselves and ask you for a break. But a lot of times, kids with anxiety really need us to be paying very close attention and knowing our student to facilitate those breaks. If the child is spinning their wheels, sitting in their seat, nothing is getting accomplished. So taking a few minutes to help facilitate a break is actually going to save you time. Again, the reduction of academic demands, we won't repeat ourselves here. Facilitating relationships. Social anxiety actually can drive academic fallout. I think it's highly underexamined at how much impairment in socialization and anxiety within peer relations can facilitate a child being afraid of school. Again, as I talked about in the very beginning, they're self-comparing. These children oftentimes feel humiliated. They want to fade into the background. So it's really important that we're monitoring their progress through longer term projects as well as just a daily task. If this is allowing your student to come up to your desk every 5 minutes ahead of time, you know that they're anxious, and you can say, Sally, if you need me throughout this assignment, feel free every 5 minutes to come up to my desk. This is encouraging the child to reach out, which is often one of the most difficult factors in anxiety. And it's allowing you to monitor their progress and giving the child a sense of control. Because remember, anxiety is a feeling of being without control. Our students want to fade into the background. We really need to protect them from drawing further attention. Even if nobody is looking at them, an anxious child walks into the room 2 minutes after the bell rings. Normal circumstances, everybody's going to turn and look who walks in. Most children realize this and it rolls off their back. The anxious student feels like a spotlight is on them and everybody thinks that there is something wrong with them. Please don't call on your students unnecessarily or put them on the spot.
Man, could you put up our first question?
Paula, do you want to read it?
It's not on our screen, so
Oh,
Nate, why
it
don't
is
you
on
read it?
everybody else's screen. Do you want me to read it?
If
Yes,
you could
please.
read it.
Okay, which of the following would be the least effective accommodation for irritability, temporary work reduction, reduced language or sensory input, check-in, check-out procedure, flexibility, or alternative location for assignments. I'll give you a minute to click on your favorite answer.
Okay, hopefully you've had the opportunity to answer our poll question. When we're talking about irritability, we empathize. This is a very difficult symptom to manage for the child and especially for the educator. This is sometimes a body experience. It's physiological. This is not a grumpy child. This is a child that's experiencing inner turmoil, and their behavior is a reflection of that experience within them. It is a symptom. It's more of a reflection of their internal state, really, than their affect or their mood. They become highly sensitive sensorially. These are the kids that can't find the right shirt to wear. Everything bothers them. They're sensitive to heat. They can become very angry, touchy. They may even be disrespectful, and they don't mean to be. It's, like I said, it's this inner war that's happening inside of them. Noise, over-arousal, and lighting is another consideration when we're looking at sensory input reduction. Taking a sensory break, this must be able to be accomplished without punishment. They need to be able to escape this environment. And what you're doing is really warding off the possibility of an explosion. This is an encouraging thing. If a child takes a sensory break and they're provided a sensory item ahead of time, something that you work out, maybe they have a stress ball or something that is meaningful to that child. When they've taken their sensory break and they rejoin you, congratulating that student goes a very long way to help normalize and help them transition back into the classroom. This could be a really great way to keep your student working. The flexibility and choice of work location, we advise to figure this out ahead of time so that we don't put too much control in the student. We need to make sure that the environment that they're alternatively going to be learning in is safe, it's prepared, it's an easy and smooth transition, it's predictable and familiar to them. We don't want to force their interactions. These guys need to be left alone. A lot of times there'll be a true social fallout. An irritable child cannot interact successfully with their peers. When they return after lunch or return to school the next day and are feeling more of an even keel and less irritable, the fallout that they had from the day before is remembered by the students and probably even shared between students. This is where that social landslide can occur. So if you have a student that's highly irritable, you may consider giving them an alternative to those social interactions. Quiet with less words. A lot of times we want to talk to our students and figure out what's happening. If you can see that they're irritable, trust me when I tell you, the less you speak to them, the better. They can't manage this. It's not a behavior, it's a symptom. Even taking time to jot things down on a piece of paper that you want to communicate to the child can go a very long way. Again, temporary work reduction. What is the most important thing that they do? Limit it to the core instruction. Giving them personal space and, again, letting them have that time to decompress and not have that sensory input, not have that interaction. Even if it's just in a beanbag in the corner of your classroom, allow them the ability to do that.
Nan, would you put up our next question?
The next question,
Could
excuse me, the next question is, what symptoms would be more likely observed in a child with depression in the primary grades? Multiple choice question. Crying, somatic complaints, social isolation, or loss of interest? We have lots of people with ideas about this. It's great.
We'll give you 10 more seconds. Okay, gang.
Okay, go ahead, Paula.
Okay.
So when we're talking about depression in a student, we see here in the picture, we have a girl, she's very sad. She's an older student. She's manifesting her depression in a very typical way, feeling blue. Maybe she's experiencing anhedonia. She's lacking interest in things she formerly enjoyed. You may see a student that's tearful. When looking at a younger student, you may see a child that's crankier, more irritable. They may be bored. They may present with somatic complaints. Their stomach hurts. Their body doesn't feel right.
We've already talked a lot about reducing work output. So here you need to be strategic. Remember, this child's mind has been physically slowed by the depression. There's slow motor function. It's a symptom. Inflexible assessments. Think about the way you may have to do an oral assessment. You may have to delay the assessment. You may have flexible deadlines where you just not, something's due, but you're going to take in consideration the depression and make sure you can extend that assignment. There's alternatives to a test in front of them. They're not going to be able to do that 3-page test, that math test, if you put it in front of them. You can chunk it. You can ask them to do any 5 problems that they want to do. You can go to the computer. You might want to just give them notes. Don't expect them to give notes. I want to say here is this child's in school. Keep them in school. We've talked about the dropout rate. So if you can get them to school, you need to figure out what's important. So prioritize. They're going to be tested on standards, Common Core, stick with math and reading, language arts, prioritize. You tell the student you understand. Come alongside your student. Appreciate them. Recognize them. Empathize with them. Tell them it's going to get better. And make sure your students can win. If you have a goal set for them, make sure it can be met. Nan, would you put up another question?
Yes, here we go.
I wish I could read it, but I can't.
Okay. It says a child as young as 5 years old can be observed to have mania. True or false?
Give you about 15 seconds there. We probably don't need it, gang.
Okay, when talking about mania and hypomania, we have a graphic on your screen that explains a lot of the typical symptoms. Some of them will be this exaggerated, some of them will be a little bit more subdued. You can see things like rapid speech or psychomotor agitation. Their motors going. You can see, you'll see this later on in our presentation when it comes to art. You might have a student that's overly elated and giddy. They may be very bossy, domineering. They can have disjointed thoughts. Here's a really important one that we need to distinguish. They might be very distractible. When your student is distracted in periods of time, that's a really good indicator that this is a mood problem and not something like ADHD. They may be experiencing a lack of sleep. They can be goal-oriented or overconfident. They might have racing thoughts. This is a very difficult symptom to manage. It's totally uncontrollable, and we really need to be willing to think outside the box on what to do to help our students that may be experiencing a hypomanic or a manic episode. We need to feed their needs. They need those sensory breaks. Let them take a lap around the yard. Get them moving. They have to be able to get that energy out. Paula referred to wanting to keep our students in school. This is a really good way to do that. If you've ever seen a manic student in a class, you'll know that they stick out. Giving them the ability to get that energy out may have them regroup, be able to come and acclimate back into the classroom and try to prepare themselves for work.
I want to say on the motor activity, it's not just the running the lap. The motor activity is fixing the books on the bookcase, carrying books, washing the board with pressure points. So don't think of it as just activity. Think of it as reducing pressure.
Yes, and if you give your student jobs within the classroom, there's a double benefit. You are actually increasing their self-esteem because they feel like they're providing a service to their teacher that's meaningful. It's still keeping them in the classroom, but they're able to kind of get that energy out as opposed to trying to sit in a desk with a pen and paper in their hand. You may want to consider avoiding social interaction. If they are having a manic episode, a lot of destructive things can happen here. If they're goal-oriented and they have a lot of energy, this may be a really good time for them. If they haven't climbed up too far on that mood scale, this could be a time of increased productivity. If you have a project that maybe isn't going to be assigned for a couple of weeks, and it could be a speech project or something that requires a lot of forethought and planning, consider giving that project to the student early and capitalizing on their enrollment. An alternative setting may be your only option. And I can't stress to you enough that getting them out of the environment when they can't control it is a very important thing for them. Consider sending your student home. I know as an educator, we don't want our kids to go home from school, but this may be doing them an incredible justice. It may not be possible for them to remain in school. This is where communication with any doctors comes into play, or the parents. The parent can probably tell you a lot of warning signs to look for when it's time to just call it a day for their child.
I want you to look at this 5-year-old girl, Hannah. I have a colleague of mine who knew I love this topic, so she shared with me a picture of her own daughter in a manic state. So if you look at this picture, this is Hannah, 5 years old, total chaos. You can see the poor motor planning. You can see anxiety manifestation and over-arousal. Her mother wrote who on the paper what she was trying to do in her family. 30 minutes later, this is still Hannah, and you can see a little bit of pulling out of a manic state, though it is less chaotic, but chaotic. But you're beginning to see an image take shape. On her third picture, this is Hannah about 45 minutes in a manic state, and you can see a more typical emotion where she's got the body parts of face, legs, feet. So you can actually see, some more thoughtfulness to her picture. This picture is Hannah on a typical emotional day, separate than what you just saw. This is Hannah, typical kindergarten picture with the sun shining, organization, and just can put a smile on your face. Unfortunately, Hannah goes in and out of mania, and this is another day where Hannah has mania. I hope you enjoyed seeing that graphic. Underachievement and work refusal, you can see this little boy, and you can say he's sad, he may be anxious, he may be fearful. You don't know. Cognitive overload. These are just all symptoms. Repeated academic failure. Well, we know what's not going to work here is, Johnny, put your head up. Johnny, you need to sit up. So if you see this, you certainly have to pull in a team and look deeper. This is where you have to know your child and if this is atypical for your child. This work refusal actually goes first. We talked a little bit in part one. What the research demonstrates, of course, is that work refusal is going to lead to underachievement. You're going to start getting absences. There's no reason to come to school. And over time, the gap widens if not addressed. And we spoke about it statistically that there's a dropout rate. We're not looking at a learning disability. We have average intelligence. We just need accommodations. We've talked a lot about, we haven't talked on this. To me, this one is important, and I haven't really seen it in the research, but I would want to know what the child is completing. So I think as an educator, you can collect data to really see what is getting accomplished during a day. You can prioritize. We talked again about what's important. We have to get out of the mindset that everything's important. Everything's not important. you must call a meeting with your parent. If you have a cooperative parent, you've got to establish consistent expectations for home to school together. Attainable goals, we spoke a lot about that. There's got to be success. Goals have got to be met. And the last thing I'd want to say there is you may have to let homework go. At some point, you just may need to.
Here we have a little boy that's socially isolated. Impaired socialization, as I touched on earlier, truly affects their academic performance. It fosters a low self-esteem and it isolates them socially because academically in their own mind, they are not up to par with their peers. This isn't just a social and emotional problem. It actually will transmit into their work quality. When they are not in line with their peers, nobody wants to partner with them. They don't have a friend on the playground. They come back in from lunch, everybody's excited, ready to work. They have relationships with each other. This is the kid in the corner of the classroom. He's not thinking about getting into the math assignment or feeling confident about himself. We need to monitor those social interactions. This is where something like a peer group, what can we put the child in? Do you have an ambassador program? Is there some type of facilitated environment where they can become a part of the group? Really understanding the parent's viewpoint, this is where that intimate knowledge of the child comes into play. They can tell you, they hear it when they come home. They know what the child's experiencing. They know their failures and fears better than anybody. This is really where we step out of the role of educator and we get into the role of nurturer, and you can come alongside that child together with their parents so they know that they're supported at home and at school. Getting a support staff that can help the child to understand what's happening. Sometimes children, especially children with bipolar disorder, certainly children with depression, they can have a misattribution and a misperception of social interaction. This is where we can get into something that I like to call is a social thinking moment. If we're monitoring their interactions, if a group of girls has come up to you with a problem, going through separately with your child that is experiencing symptoms, talking about the sequence of events, where the train went off the tracks is really important in getting them to understand what they can better do the next time. That's when we don't focus on what went wrong right here. We focus on the moment that it went wrong, and then we turn our thoughts to, if we could do X, Y, and Z. Facilitated lunch. I know some campuses have something like a lunch bunch program. Others can go and have lunch with the teacher. I mean, if you remember being a student, how important did you feel if you got to win lunch with your teacher?
And then we're going to put our last question up for the audience.
Okay, and it says, what may be a non-negotiable accommodation for a child who is having a medication initiation or change? Permanent bathroom pass, opportunity for nap or rest, late school start, or all of the above?
The first thing I want to say when talking about accommodations before we get into those is sometimes no accommodation can facilitate learning. This is where we have to learn to lose. Sometimes when a child is going through a medication and initiation or change, there's simply very little that they can do. You may see a child that sleeps every day. This is a very real thing. They can't control it. They're drugged. Having consistent access to water and snack, a lot of medications will drive increased thirst and hunger. And of course, we don't want our children suffering through something like that they can't control. A lot of times we'll see increased urination and diarrhea, and there's nothing more embarrassing than a student having to keep asking to go to the bathroom. Let them go. Let them know ahead of time that they don't have to ask. You can develop a signal where you know where your student's going to be. You're keeping them safe, but they have access to the bathroom anytime they need it. We need to involve our nurse or our healthcare staff. If you have a child that's on medication, especially going through a change, there are very real risks involved. Our nurses need to have inserts to every package of medication with dosages that these children are taking. You yourself have to be educated on what the warning signs are, things to look for. Giving them maybe an augmented physical education. A lot of medications come with risk factors as far as increased physical activity. Giving them a block of time for work completion. You may have the whole week the child got nothing done. You're going to have to organize a way to prioritize those assignments and give them an extra block of time to get them completed. This is when we don't send homework home. We are happy that the student is at school. We want them to feel the least amount of stress possible. We can't really empathize enough with what these little guys are going through when they're having a medication change.
Because of time, we're not going to discuss the symptoms a lot on the next 2 slides, because we want to have time for your questions and answers. So we're going to go through the accommodations. But we should decipher here between ADHD and bipolar.
So when you're looking at bipolar disorder, we know that this is an episodic and cyclical illness. Even anxiety, this is a situational thing. ADD is unremitting, it doesn't change. But what's interesting is that the fidgety, the paying attention, a lot of those accommodations are going to be the same across the board. The main difference to note is that kids with ADHD often respond to novelty, whereas children with bipolar disorder do not. Offering them choices, giving them a break card so they can gather their thoughts and come back to instruction. Keep them close. You can really get a lot further with a child that's very close to you, even if it's just a touch on the hand or a touch on the desk, to motivate them to get back working. It's very important not to draw attention, and they already feel ashamed. If they could do better, they would. Give them an alternative to a desk. They may be standing in the back of the classroom. Again, they may be over in the corner on the chair in your reading nook. It's very important to give them a little bit of flexibility. If they do poorly on an assignment and you know it's not reflecting their true base of knowledge, allow them to redo it. Executive functioning and working memory. If you look on the AET website, the name is escaping me right now, but there was a wonderful webinar that was given about executive functioning and working memory. We can't stress enough how this is probably the single most important area to educate ourselves on how this touches children with mood disorders. We will tell you, as controversial as it may be, if you have a child that has a mood disorder, they need a neuropsych evaluation. And oftentimes the best place to receive that is outside the educational setting and have a full medical neuropsych done. The discrepancy between their ability to learn and their achievement is typically documented by a normal IQ. This student got 115 IQ, but they are 2 academic years behind. Their ability to organize, strategize, and plan is going to definitely become more apparent when work becomes more complicated and requires more independent planning. These students get left behind in a very noticeable way. Giving them a set of books for home is a non-negotiable. One of the things that we like to do is color code their books with their folders or dividers so that less cognitive load here. They're able to quickly correlate what it is that they need to do. If you think of the cognitive load for a child like this in terms of having a plate over the top of their head, maybe they can only have 3 items on that plate. The second you put a 4th item there, one of them drops off. So one of the ways we can reduce cognitive load is helping to teach them an organizational system, a check-in and check-out procedure that they do every day. Repetitive, rigid routines is where the child will now not think, where am I supposed to be? What am I supposed to be doing? And those faculties will be better oriented towards the task at hand. Give them their times tables. Give them notes ahead of time. Do we want our students to be able to have note-taking skills? Absolutely. But if they can't achieve that goal, they're missing out on instruction and the benefit of an education. So getting those notes to the child prior, so that while other children in the classroom, if they're in a gen ed setting, are taking notes, your student has the notes in front of them. So they're getting double duty learning. They're able to focus on what you're saying auditorily and read it in front of them. Prioritize those assignments. Make sure that you are, do they really need to learn about Christopher Columbus today? We'd like them to, but I think it's a lot more important to focus on the standards as we had mentioned earlier.
We're sorry we're a little rushed. We want to get to questions and answers. I also forgot to tell you that you have a handout, and if you don't have the handout, you can download it on the AET website. We only covered partial accommodations today because of time constraints.
We'd like to really thank you for your participation and most importantly, your interest in this topic. I'm sure you guys can tell that Paula and I are both very passionate about this group of students that are being left behind. So thank you so much for taking your time to join us today.
We're going to get back to Nan.
Okay. Paula and Chrissy, you have some questions here. I will read the first question to you, and it's coming all the way from the United Arab Emirates. The question is comorbidity common? I have this type of child with symptoms of ODD. It can be fairly severe, but in this country, which was the United Arab Emirates, parents do not seek out help. Hence, I'm often in a dual role. Teachers have to be trained in terms of how to respond to avoid episodes.
That is a wonderful question. Thank you so much, Nan, and thank you for the participant who asked that question today.
Okay, and one other thing, Chrissy, before you start, did you want to stop your screen share?
Sure. Let me get that.
And turn on your camera, your video.
Here we are.
Okay, great.
Hi, everybody. That's a wonderful question. When we look at comorbidity, it absolutely is very common, specifically with a mood disorder and ADHD. Some of these symptoms overlap. Sometimes it is a separate diagnosis. Oftentimes you'll see a student diagnosed with ADD or ODD prior to receiving a mood disorder diagnosis. ODD is a very big challenge. One of the things that you should really be looking for, number one, if you cannot enlist the parent, is just paying attention to the symptom and really avoiding kind of that diagnostic language, because that's not our role. We're not doctors. But how often does this happen? Is this something that is constant? Is this something that you notice during chunks of time? Looking at what is presented to you and finding the appropriate accommodation as an educator is really all you can do here. Certainly wanting to enlist the parent is a very valuable thing, but there's going to be times when you are not going to get help. There's times when the parent doesn't get help. So what we each need to do is take up our own torch, educate yourself as much as you can on these accommodations, and put them in place. And the last thing I'm going to say is, you may not have an IEP, you may not have a team together. One of the things I want to challenge educators to do is to be the initiator of those services. If you see a child that's struggling, don't be afraid to bring that to your superior and say, we need to call a meeting. We need to figure out how we can support this child in their school environment.
Okay, you have another question that's asking, what about diet, sugar intake, and its effect on mood disorders?
There's lots of research. We're not physicians, so we don't want to speak to the research there. So I don't want to be biased in what I say. So I think I'm going to allude back to the research. There's controversy. I think a good diet is important. Strong vitamins, especially in vitamin Bs for depression and fish oils. I think that is all important. But I don't think I want to touch about a specialized diet of no additives or no sugar or no coloring. because of the controversy.
If you want to refer to Dr. Rosalie Greenberg's research, she talks about PANDAS. She has a lot to say about diet. But currently, the research, when you have a biochemical disorder, does not support that any change in diet can really have any meaningful effect on a mood disorder. But we do know that diet plays a key role in all of our lives. So certainly having a healthy diet that's lower in sugar is going to benefit any child, but the correlation between that and a mood disorder is really unproven at this point.
Another questioner asks, as an ET, I have an 11-year-old student who becomes highly anxious when his father goes on business trips that last a few days. I've suggested a calendar marking when Dad will be away, using FaceTime to communicate with him. He sees an anxiety therapist. He is still presenting with panic attacks. Any other suggestions?
Well, I love the suggestion of Skyping and keeping close with the technology today. I think that's wonderful. I think the therapist should probably look a little deeper into what could that be. You know, is it a sound family? Has there been fighting in the home, or maybe they hear threatening that Dad's going to leave, so when Dad's on a business trip, they're scared?
Calendaring that is an excellent idea. The big thing with anxiety, and this isn't just children, it is a constant sea of questions. Why? When? What? What if? So if they can have a visual calendar that articulates not just by date, but something that is meaningful to their daily operations, that is invaluable to that child. If a child is indeed having panic attacks, that therapist should really think about having a very candid conversation with the parent. That's when they really need to talk to the doctor. It's really unfair to expect a child to will their way out of a true anxiety situation or a panic attack. Medication may be indicated, and certainly only a physician can make that call. But it's really important that we respect that this isn't just a worry. If they're having a panic attack, that's a physiological response to anxiety.
That ed therapist has got some good accommodations in place, and that she's digging deeper is even greater.
Very encouraging.
One more question. Do you think that a 14-year-old is ready to know that they're diagnosed with bipolar disorder and explain it to them?
Absolutely.
And I have to pony that also. Yes, absolutely.
Of course. You know, when I think back, when my child was diagnosed, and I will be the parent in this, in the answer to this question, because I have meaningful experience here. I remember one of her counselors, and we've seen many, saying, it's sort of like naming the devil. When a child is experiencing these things, it's very scary to them. This is their life. This is what's happening to them every single day. At 14 years old, they absolutely should be a partner to their treatment. They should know about their medications. They should be researching their illness themselves and getting a better understanding of what's happening within their own minds and their own body. This doesn't have to be, this is where stigma comes in, because the only real reason that we wouldn't share is because of fear and quote unquote labeling. But if we start to look at this as more of a medical problem than a psychological or a emotional issue, it really takes away the reservations of whether or not we talk about it. Talk about it, talk about it, talk about it.
And you might want to find the right person. It might not be the parent. It could be the therapist. It could be the medical physician. So you want to get the right person too.
Absolutely. And what's really important too, if the therapist decides that that's a conversation that they should have with the child, dialogue with the people closest to the child is important, because once a child knows, they already know something's wrong. They need to hear from the people that mean something in their lives that they accept them, that they're ready to face it with them, that they're behind them. I'd like to give you a reference. Dr. David Miklowitz has written a book called Family Focused Therapy. It is the only evidence-based treatment in place to help families and caregivers and the diagnosed person psychosocial interventions to respond to the family dynamic of bipolar disorder.
Thank you for that question.
Okay, and we have one more, and I think this will be the last one. The question is, how young is bipolar typically diagnosed in your experience?
It used to be called early onset bipolar, pediatric bipolar, and in the past, pediatricians really wanted to stay away from the diagnosis. You're asking about how early? Well, Hannah has been diagnosed and she's 5.
And it's not typical. Usually the illness doesn't really manifest until later adolescence. That you typically see people in their early 20s really getting diagnosed. Remember, it takes 7 to 10 years to get an accurate diagnosis of bipolar disorder. So what happens, the major diagnostic dilemma is that children present with different symptom patterns, and specifically in their duration. So currently, the only legitimate way to diagnose a child with early onset bipolar disorder is to give them a DSM-5 diagnosis. That means they have to meet the full durative criteria for episodes of depression and mania or hypomania. My child received her formal diagnosis at age 9, but she was clearly suffering from bipolar disorder since she was 5 years old. But it took that many years for her episodes to reach the length of time required to make that diagnosis.
And we also want to refer back to the new DMDD, which is the disruptive mood dysregulation disorder. You can look that up in the DSM-5. That's capturing those students with irritability and tantruming, excessive irritability and tantruming. That goes from age 7 to 16. And the other is you're going to see a lot of our students with mood disorders having the ADHD label first, because historically that's where physicians are going to go first because it looks similar. But again, you're looking at symptoms and the symptoms do overlap. So it's tricky, but you as a professional, the parent, educational therapist, from listening to parents or teachers, you can see if it's deeper than just being fidgety or not being able to pay attention. You need to find out what's going on at home.
And I'd like to touch on that DMDD talking point that Paula just referred to. So a really important difference is a lot of children that had unremitting irritability, but did not have cyclical mood. They did not have mania. They were highly irritable, were receiving the diagnosis of DMDD. And it was sort of initiated to find a diagnostic home for students that had this unremitting, explosive irritability, but did not have the other symptoms of bipolar disorder. We think of diagnosis as a pendulum. It kind of swung really high in one direction where we had children being overly diagnosed. That's kind of a natural course of action. And it's more coming back down to the middle again, where we're really trying to distinguish between, is this really a bipolar condition or is it something else like ADHD or DMDD? But again, if you have these suspicions, I would if you're going to speak with a parent or another professional, stick to the language of symptoms, because one of the worst things that can happen is we as an educator, we know what we see, but we're not doctors. We tell a parent, I think your child has ADHD. The parent runs, the pediatrician, not even a psychiatrist, can give them ADD meds, which if there's an underlying mood disorder or a bipolar condition, catastrophic results can take place when a student is inappropriately medicated. So again, really focusing on what symptom you're seeing, and in your practical practices, how to respond to that symptom through an accommodation. But when talking about you think a child needs an intervention, stick to what you see, write it down, how it manifests, what it looks like, stay away from those labels, and don't be afraid to speak out.
This questioner asks whether the book about family-focused therapy is also applicable for families with adults with bipolar disorder.
Absolutely. Really, this book was designed, it is a communication enhancement training as well as therapy. So the book was originally designed for clinicians. So you'll find, you're all very seasoned professionals. It is really geared towards clinicians. So it's for the more astute reader. But it is designed primarily for post-hospitalization. So it's a program and a therapy module that is put into place for people who have been hospitalized at any age, when they come out of the hospital, how they go through therapy, re-entering, setting reasonable expectations, how to communicate within the family. I personally have gone through the entire FFT program at UCLA with my own child and Dr. Miklowitz personally. The book is wonderful. I encourage you, if you have any more questions about bipolar disorder, read him. He's a great resource.
Another questioner asks, and it looks like this is the last one, what is the difference between bipolar and bipolar 2?
Well, we're going to give you just we are not doctors, so I encourage you to look at the DSM-5 to see the really involved answer to that question. But what I will say is bipolar 2 is marked more by more depressions, longer periods of depression. They spend more time in the depressive state, and usually their mania looks like hypomania. So it's a lower level of mania where it does impair functioning, but they can still function. Bipolar 1, again, you need to look these up at your own time in the DSM, but bipolar 1 is more full mania. So that's extremely impairing. They tend to become hospitalized more for manic episodes and can even have psychosis.
Thank you again so much for sharing with us today. And one other thing that I want to mention is that there will be a link in the email that you get tomorrow to an evaluation form. It's a little survey, it shouldn't take more than a few minutes. We really, really appreciate your input and any suggestions that you may have. So, Paula and Christine, thank you so much for sharing your expertise and expert knowledge. You've given us so many excellent ways to accommodate and support our students with mood disorders. And thanks to those of you in our audience for attending today's Association of Educational Therapists webinar. This webinar was recorded. The recording will be available on the AET website, www.aetonline.org, where you will also find a link to the handouts and to a webinar evaluation. We very much appreciate your feedback. We hope that you'll share this webinar with colleagues and friends. For more information about educational therapy and membership in AET, please visit our website. Again, it's www.aetonline.org.